more about the elderly and trauma because I think it's important to, when we're talking about the elderly and their unique station in life and what they've experienced and are experiencing, we need to keep in mind that any change for any of us really involves loss. And maybe we've never thought of it that way, but anytime we change anything, we're saying goodbye to something. We're turning away from something that maybe is very familiar and comfortable, but it's really important to understand that loss needs to be grieved. And I think we need to give people permission to grieve that loss. And if we can kind of begin to focus on that and think about that, and rest in that, it's going to make it easier for the elderly to and give them the space that they need when they're dealing with all these new things going on in their lives with COVID and what's happening there. This is even more important because there's many factors that make it more or less difficult for elders before, during, and after a traumatic event, and a lot of them we've already talked about. Impaired cognition, a social network that's unavailable or decreased. Well, that's really true right now. A limited financial situation or medical, mental health problems, history of exposure to a traumatic stressor, maybe having a substance use disorder that's never been recognized or it's been misdiagnosed, language or cultural barriers. So, but we know that trauma does pose a threat to the successful aging process because it interferes with a lot of our relationships and our productivity. So it's really important for us to understand the importance of that. And when we approach and we work with the elderly, we have to be aware of this reality. There's some assessments for elders I listed here. I put down the author, what they are, the post-traumatic disorders checklist. There's also a trauma symptom checklist. And I actually quoted Briere before in another quote. And then there's a successful experiences checklist as well. And then my friend Gabriella Grant, who lives in California, she gave me permission to use this. I thought this was really, really good because you don't have to come up with some really fancy schmancy screening tool to screen for an elder for trauma. You can just ask them some key questions like, do you feel safe speaking to me today? You're asking permission. You're giving them the power to say yes or no, rather than just assuming that it's okay. Asking them, do you feel safe speaking to me today? If not, what would help you feel safer? Or do you feel safe at home today? If not, how can we help you feel safer? Did you feel safe at home as a child? That's different from it. Were you ever abused? If not, how does that affect you today? Because you're beginning then to develop a bridge from their past into their present. And that's something that a lot of people they never think about that. I certainly never did as a clinician. But I think it's really important to look at that safety piece because that's a really crucial part of being trauma informed. Because in all of us, not just elders, but in all of us, we have reminders or triggers, those things that will trigger our limbic brain. So we flip our lid and we go into fight, flight, or freeze. Things like having a lack of control, threats, witnessing assaults, isolation. That's a big one for us right now. That could be a big trigger for a lot of folks. Having a directive approach, being told what to do, lack of privacy, removal of clothing. You don't know somebody's history. When I had my heart attack 5 years ago, they rushed me by ambulance to St. Mary's in Madison, and they took me right up to the cath lab. I didn't even go to ER because I didn't realize at the time I was having the widowmaker heart attack, which only has a 6% survival rate. So time is of the essence. So they get me in this room. They take me off the gurney from the ambulance. They throw me on the table, not throw, but they put me on the table. But a nurse started unbuckling my pants and started pulling my pants off. Now that could have been a trigger for me. It wasn't, but it could have been. But what she did beforehand is she told me what she was going to do before she did it, which made a big difference because I was already in a heightened state of freaking out because I'm dying. Literally, I was dying. I was not feeling very well. But she said that beforehand. So that removal of clothing can be a very powerful trigger. We need to be aware of that. Stepping into a patient's experience, asking permission, being touched or watched, loud noises, darkness, intrusive, all these things. This is not an exhaustive list of triggers. They're different for everybody. And when you're working to become trauma informed as a person, a practitioner, or as an organization, you want to think about your day to day, and and think seriously about, are there things that I'm saying or the way that I'm saying them or things I'm doing that could be possibly making somebody feel uncomfortable where I'm triggering them into a fight, flight, or freeze situation. I did that as a clinician with my clients. I triggered them a lot, not knowingly. I didn't mean to. That wasn't my plan, but it was my ignorance, my lack of knowledge and awareness about all this is where I came from. I thought I was being helpful, but it turns out I wasn't. I mentioned earlier that there's a trauma worldview. And if you were to really get at the essence of a lot of trauma survivors and get to the core of who they are, what they think, they would probably say something like, no place is safe. My own actions, my own thoughts, my own feelings are unsafe. Other people are unsafe. They can't be trusted because everyone who ever told me they had my best interests in mind hurt me. And so I'm going to defend myself by just not trusting. You're going to have to earn my trust. I expect crisis, danger, and loss because guess what? That's the script I was given as a child. That's my life script. My life has been one crisis after another. It's been very dangerous. It's been painful. It's been scary. I've had a lot of loss, and I'm just expecting more of the same. Why wouldn't I? I have no worth, no abilities. That's that cloak of shame I was talking about. So it's because of that worldview we need to be looking at being trauma informed. That's the important piece. I have another video I want to play for you. This is from the Cleveland Clinic, and it's about empathy. Why would I talk about empathy? Well, empathy is really, really important because that is the glue that holds us together as human beings to connect with each other. We need to have that empathy. And if we don't have it, we can't connect meaningfully with others. So I'm going to play this video. It's from the Cleveland Clinic, like I said. I will do a little minor trigger warning. I have played this many, many times over the years for different audiences, and sometimes there's people in that will respond in a very uncomfortable way because not that it's not scary. It's just there's some images that could be troubling for some, and I just want to make you aware that, again, and remind you to take care of yourself. So I'm gonna play this. There's no talking. It's just little thought bubbles, but I want to play it and then we'll talk about it. Okay, so I really like that. I really like this video because it just does a nice job of explaining empathy. And I usually, if we were live, I would ask you, what did you take away from it? And oftentimes I will hear people say, that all of us have stuff. We all have things in our lives. And what I like about this video is it shows both the staff of the hospital, the doctors, the nurses, support staff, as well as the patients. And they all had a little thought bubble. They had a story. Now, unfortunately, we don't walk around with thought bubbles. We don't know sometimes where somebody's at, what's going on with them. They may give us some behavioral cues. We can see maybe somebody's upset or confused. And if we're trauma informed and empathetic, we're going to tune into that. We're going to stop and say, "You look confused. How can I help you feel more? Tell me what's going on." But we all have stuff. I mean, every one of us. That's why trauma informed care is for everybody. It's not just for our clients, our consumers, our students, our patients. It's for all of us because we all have stuff. We bring stuff into our work, and we need empathy. We need to be able to connect emotionally with each other, connect those feelings and needs. What do you need? What are you feeling? I have the spectrum of empathy on here because it really shows the range of the ways that people can respond. Pity on one end says, I feel sorry for you. I feel bad that you're going through that, but nothing I'm gonna do about it for you. I can't help you, but I feel bad. Same with sympathy. It's kind of like the same thing. It's kind of like I feel for you, but doesn't move me to do anything, to act in any way. It's only when we get into empathy and compassion where we say, I feel with you or I am moved by you. That is where the connection is. That's when we have those two things in abundance is when we can connect meaningfully with others. And that to me is the foundational bedrock for being trauma informed, is having that feeling of empathy. The first rule in trauma informed care is do no harm, and it's not a new idea. It goes back to Florence Nightingale. If you remember, she said the very first requirement in a hospital is that we should do no harm. And then Dr. Hodis colored that a little bit more clearly around trauma informed care when he says that we need to presume clients we serve have a history of traumatic stress and exercise universal precautions. What does that mean? He says that we should just basically treat everybody that we interact with as if they have an ACE score of 10, that they have a significant trauma history. Because if I'm coming to you for services and Scott has never had a trauma in his life, he's got a 0 on his ACE, he's had a really good life, and you treat me as if I'm a trauma survivor, in that you're going to be kind, compassionate, loving, caring, that's going to feel good, whether I have a trauma history or not. So no harm done, right? That's all good. But if Scott comes in and he has, like I do, an ACE score of 5, and I've had a lot of history and a lot of heartache in my past, I'm coming in, it's going to feel different. If you're truly a trauma-informed organization or practitioner, it's going to feel different. I may not trust it for the reasons I've already mentioned earlier, but it's deep down, it's going to feel good, and I'm going to want more of that. I may not trust you right away, but it's going to feel different. And it does make a difference. I remember talking to a colleague once. He was working at one of the counties in Wisconsin that became trauma informed. It was early in their transformation. He was talking to a female, one of their clients. And in the middle of the conversation, the woman just stopped and gave him this funny look. And she said, "Why are you talking to me like that?" And my friend is like, inside, he's like panicking, like, "Oh no, what did I do?" Because he's trying to be trauma informed because that's what they're working to do. She said, "Nobody's ever talked to me with that much respect before. People usually talk at me, they don't talk to me." So she noticed it, she called him on it, but she didn't forget it. I think that's really important because the words we use have tremendous power. So that connecting is important. Trauma must be seen as the expectation, not the exception, in all of our systems. So being trauma informed goes from the old medical model, but what's wrong with you? And we're so focused on people's symptoms and illnesses, right? We're very comfortable in that space because it's all we've really known. We go to the doctor, the first thing they want to know is what are your symptoms? What's going on? What's wrong with you? In behavioral health, we might look at that too. What's wrong with you? What are your symptoms? And then it's all about symptom reduction. Trauma informed, we go to the next step where it says, what happened to you? What's your story? I just don't want to look at your symptoms and try to reduce them. I want to understand them. I want to understand the behaviors that you're engaged in because there's a reason for them. You're trying to get a need met by behaving a certain way. So what's your story? What happened to you? And if I'm a good practitioner of trauma-informed care, I'm going to create that safe space. I'm going to establish rapport with the person and give them permission, if they want to share their story. They may not want to, not right away. That's okay too. And then the next tile says, what's right with you? Because no matter how broken or difficult a person may be in their behavior and trying to react with them, there's a lot more right with them than there is wrong with them, because they're still alive, they're surviving, and they're still in the game called life. They're the CEO of their life. So I want to listen for and hear those victories in your life. And maybe I'll even ask you, what are 2 or 3 things you're most proud of? Most trauma survivors are not used to being asked that question, because we're always focused on the negative. What's right with you? And then I would want to capture those little moments, those things I've noticed, and give them back to that person and share with them with a heartfelt message that I'm really amazed that you were able to go through so much as a child and survive all that. And here you are. You have a lot of inner strength that you're not even aware of. That's powerful, but that's being trauma informed. Trauma informed means, really, what I love to see is work cultures change. I love to see them change their cultures so that everyone is feeling this, not just the client, but everybody. Being trauma informed means that you acknowledge that trauma is everywhere. And when we really screen and assess for trauma, we are amazed at how common and how pervasive it is. We focus on how trauma may affect a person's life. We've been talking about that today, and how they're going to respond to support services or not. It's about creating that safety of being trustworthy, being collaborative, being strength-based. And I hope it's not flavor of the day. And I've had people come up to me sometimes at trainings and say, Scott, all this sounds really good. I like the way you're presenting it, whatever. It sounds great. But let's face it, 5 years from now, we're going to be talking about something else. We're going to move on to the next thing. This is just flavor of the day. And I always have to take a deep breath and count to 10, ground myself and say, well, let me ask you this. If treating people with care, compassion, empathy, and yes, even love is flavor of the day, then what does that say about the state of our profession? What have we settled on as our status quo? Because everything I'm talking about today, folks, it should be standard operating procedure. And in its simplest form, it's kind of like we go, well, yeah, duh, we should do that. We should know that. We should be doing that, but we're not. We've moved away from that. We've kind of tacked away from our original mission of caring for people, and we're more concerned about the systems and the payers and the finances and all that, and the rules. I work at the state, so I'm all about the rules. But we've lost track and we've lost focus on people. So we got to get back to that. Being trauma informed means we do what we can to avoid re-traumatizing people and hurting them. Are we going to be good at it every time? No, we're not perfect, but we're intentional. We keep trying to look for ways that we may be inadvertently triggering people into a fight, flight, or freeze situation, because that's not comfortable and that's not helpful to their recovery and to their own well-being. So we try to understand that. We want to appreciate that many of the problematic behaviors we see in these people, they're just attempts to cope. It's what they have in their toolbox. And we strive to maximize choices for people, giving them a choice, talking to them, collaborating with them, being culturally competent. Those are really important pieces. Back over 10 years ago now, my goodness, we had an advisory committee for Wisconsin's TIC advisory committee, and they came up with, okay, what are the guiding principles of trauma-informed care in Wisconsin? And they came up with this graph. And it's interesting because the biggest circle, healing happens in relationships. You've been hearing me talk about that today. But then you got all these other bubbles that touch that. They all play a part in that relationship, right? Promoting safety, earning trust, and providing holistic care, respect human rights. We could spend an entire training talking about any one of these. And you could take this graphic back to your place of work if you're working somewhere, want to become trauma informed, and some really constructive conversations could be around, are we doing all these things, or where are we not doing them, and how can we do it more often? You could have brainstorm sessions and conversations about any of these. And then about 2017, Dr. Murthy, he was the Surgeon General for President Obama, and he's now the Surgeon General for President Biden. He said at a conference back in 2017, the oldest medicine in the world is love and compassion. And Twitter literally blew up with this quote. And I thought, this is perfect. I knew just what slide I wanted to put it on because that's what this is about. The oldest medicine, the best medicine in the world is love and compassion, and it's in short supply. So we have the 4 R's of trauma-informed care. This comes from the Substance Abuse and Mental Health Services Administration. We call them SAMHSA. They talk about the first step. The first R is realization, realizing the widespread impact of trauma and how it affects people and how they recover. We're talking about that today, right? With that realization, you move into recognition. You recognize, you start noticing the signs and symptoms of trauma in clients, in their families, in staff, and others within the system. And you could also, when you have that recognition, then you can begin to respond by fully integrating knowledge about trauma into your policies and procedures and practices. It takes time. Any work culture that wants to become trauma informed, it's probably a good 5 to 6 year project. And it's going to be ups and downs and messy, and you feel like you're taking one step forward and 2 steps back sometimes, but it's always worth the effort. Because I've been in some trauma informed systems within the state, and they just feel different. I can't explain it. There's a different vibe going on. People are happier, they're more engaged, they're not quitting, they're not leaving the profession. And then the last R is doing what you can to resist re-traumatization. That's not, and it's for not just children, but anybody across the lifespan. Because a re-traumatization is a situation, or could be an attitude, or some type of interaction, or the environment that would replicate for that person the events or dynamics of that original trauma. And the challenge is it can be obvious, or it can be very, very subtle. But it's always usually unintentional because most helpers do not want to hurt the people they're trying to help. I certainly didn't, but I did. I can think of many instances where I re-traumatized one of my clients based on my ignorance and just not knowing. And it's hurtful. And it doesn't help them recover, doesn't help them achieve a better, higher quality of life, and it doesn't help us as helpers. So there's 6 key principles to a trauma-informed approach. And we've been talking some of these today, but having that safety, we've talked about that. Being trustworthy, being transparent in both our written communications and our verbal communications. How do we build that? What does it look like, sound like, feel like in our place of work, and how can we build more of that in? Peer support, how do we engage peers, those with lived experience? Can we do more of that? Can we be collaborative with people? And we do that by empowering them, by giving them a voice and giving them a choice in their treatment, in their program, where we just don't tell them, dictate to them what they're going to do. That's the old model. That's the model that doesn't work very well. That's the model that I worked in. The new model, the new paradigm would be giving people a voice, a choice, empowering them and collaborating with them by saying, yes, I have some expertise as a helper, but you also have expertise because you've lived your life. I haven't. Let's bring our expertise together in partnership. Let's come up with a plan that we both can live with. And then again, being very sensitive to the cultural, historical, gender issues. Again, how do you do that with safety? Just to kind of give you an idea, creating this welcoming, calming environment, maintaining respectful physical, emotional boundaries, having a safe place to talk. If you're having confidential conversations, if people can hear you in the hallway, or if you can hear people in the hallway, they can probably hear you. So being trauma informed by putting a white noise machine in your office if you can't soundproof, being aware of that, being open to outside parties, advocacy, and consultants to come in and help, and being willing to ask about a person's abuse and address current risks to safety. We have to go there and open that can of worms. We have to be safe and strong enough in our own selves, in our own recovery, in our own trauma histories to be able to do that. And then we need to communicate in an empathetic way. And sometimes all of us have jargon in our world. I know I did. I used every one of these words when talking about clients before I knew anything about trauma-informed care. I call some of my clients manipulative, non-compliant, attention-seeking, frequent flyers, in and out of detox like every 4 weeks. There's other ways we can reframe these to describe somebody. Like in other words, instead of saying somebody's manipulative, we could say they're creatively trying to get their needs met. It's not lying, it's not inaccurate, it just takes away some of the sting, and it's the judgments. The words we use can be very judgy. We don't want to do that, because the labels that we use to describe people, we get them stuck. We keep them stuck. And when we label people, we judge them, like I said. And when we judge people, we lose the ability to connect meaningfully with others. And here's the thing about judging. Brene Brown talks about this. She says, if we're really honest with each other, we human beings love to judge. We kind of like it. It feels good. And that's not helpful. We've all done it. I know I've done it. I just talked about it. But we have to be making observations, not judgments. That sounds easy. Not so much. Not so much. So we have to be aware and have that awareness of when we judge people and we think they're just a borderline, or that elder is just a pain in the butt and he doesn't get along with anybody, we've lost our ability to connect with them because they're going to be just stuck in that space and stuck in that what we think of them, and we're not going to put in the energy to get to understand them and figure out, well, what's the adaptive function of that person's behavior right now? What need are they trying to get met? TAC looks like avoid forcing eye contact, being aware of your proximity to people, because sometimes people are very uncomfortable having somebody in their bubble. With going on with COVID, that hasn't been as big of an issue because we got that 6 foot thing going on. But before COVID and after COVID, once we feel comfortable again, we need to be aware of that proximity. Avoid asking too many questions of somebody where it sounds like an interrogation. I would rather have a conversation with a client rather than an interrogation. If I have an assessment form and I've got to get all this data, is there a way that I can gather this data by just talking to that person? Yes, it may take longer, but that's part of being trauma informed, is taking the time, pacing. Pace those meetings. Don't have them adapt to your schedule. You kind of adapt to them a little bit. And if they're uncomfortable, take a break. Being strength-based, those past successes, asking permission before touching or hugging. Again, providing choice and asking about the client's goals and priorities, because again, that's giving them a voice and it's giving them some power. You're empowering them to talk. During emotional times, ask somebody, how can I support you right now? I don't know what to say to you. What you just shared with me is really, really painful, and I don't have the words, but I just want to be here with you. How can I support you? What do you need? Or if the trauma story overwhelms you and leaves you literally speechless, can you be strong enough to just sit in supportive silence and not recoil in horror what you just heard? Because that recoiling in horror will reinforce the shame that people feel deep down about their story. So we have to be willing to do that, but we can't do that unless we've done our own work and we're strong enough in our own selves that we can be that strong person to just be with them. Providing information about services that'll be provided, the who, what, where, when, how. And you need to be clear about that. That's part of being trustworthy and transparent and being consistent and having those clear directives. Be prepared to repeat information many times, because if somebody's brain is in fight, flight, or freeze and they flip their lid, the limbic brain and the reptilian brain are driving the brain bus at that point, and we need to be aware of that. And sometimes we have to repeat information many times so that they will get it in the way that they need to receive it, because the part of their brain that would do that needs to be online. So we need to be aware of that. Comparing the two systems, the traditional system, looking at an elder, what's wrong with you? We have an elder that isn't fitting in well here. We'll say it's a skilled nursing facility. They have limited social skills. They're not making any friends. They're isolating. So it's this whole, what's wrong with you? What's wrong with this? What's wrong with Joe over there? Joe's not remembering anything. And if you don't go any further than that, you're not going to really want to, you're not going to connect with Joe, and you're not going to do anything that's going to be transformative. Trauma informed means, has Joe experienced a significant loss or transition recently? What's happened to him? Is there a medical condition we need to be aware of? Is there a medication interaction? Is there a trauma history? Have we screened and assessed for trauma? And maybe we find creative ways to get those stories. Tell me about your childhood. What did you do? Did you feel safe growing up? Trying to get that information to find out. I did a lot of, when I was in grad school, a part of my grad work was I was going into elders' homes up in the Fox Valley. And I got their names through Meals on Wheels, and I asked permission if I could come and just talk to them. And I did a lot of reminiscence therapy, but I heard some amazing stories, and a lot of stories as I look back. Non-trauma informed Scott didn't get it then, but now I look back and I go, yeah, I could hear, I heard a lot of aces in their stories. But neither me nor them, we weren't going to connect that. But there are stories there, and there's opportunities to educate. But that's what being trauma informed would be: asking those questions, being curious. So responding to people in need is to engage them, develop the rapport, being that calm, soothing person and environment that they're in. Give them your undivided attention and do that active listening. Really listen to hear. That's where empathy comes from. Give as much control and choice as possible. Validate their experience, because I feel a lot of shame on what happened to me growing up. But if somebody tells me, Scott, I get what you're sharing with me, and if I had that happen to me, I would be doing probably worse than you are right now. And you know what? When normalizing, it's normal to feel the way you feel about it. It's very normal to behave a certain way given what you've been through, what you've been taught. It's normal, and it makes sense that you behave a certain way. But are you open to learning about new ways to deal with life that don't involve hurting yourself or somebody else? Being able to assist them means teaching them grounding skills, doing some deep diaphragmatic breathing, feeling their feet on the ground, making the proper referral, knowing where to refer somebody, and doing what you can to avoid re-traumatizing them. Here's some more validation tips. What happened was not your fault. You're not to blame for what happened to you. Thank you for trusting me with such a personal, private experience. And anybody can share this. It could be a doctor, it could be a teacher, it could be anybody could be sharing this with somebody. You deserve help in dealing with something so difficult. Would you like me to connect you with someone who could talk to you about this? That's validation. But we need to broaden our view of trauma-informed care, because what we've been doing until fairly recently has been looking at TIC and these silos. Trauma-informed care for kids, for young adults, for older adults, elderly. And we need to be thinking about trauma-informed care across the lifespan, because a lot of our elders out there have an ACE score. They have a story, they've just never understood it. And we need to understand it and help them understand it. So we have to broaden our view by really following all these concepts across all ages. Person-centered planning, compassionate communication, being confidential, all this plays a part in TIC. So how can we begin to take care of ourselves? Well, Dr. Richie Davidson at UW-Madison talks about these 4 constituents of well-being. One of them is forming some resilience. How do you do that? Well, we're going to talk more about that in a minute, but developing a more of a resilience to adversity that comes at you. Another form of well-being is having a positive outlook. There's something called loving kindness and compassion meditation, which you can look up. It's very easy to do, but they found that you can actually begin to improve your brain circuits with just 7 hours of training. By doing this loving kindness and compassion meditation, you can begin to change your outlook to be more positive. That's really, really important right now with COVID. And that's something I've been working on myself, is trying to have that positive outlook and working on that loving kindness and compassion meditation. Another one is being more mindful, because our attention, 47% of adults' waking life is spent not really knowing what you're doing. You're not paying attention to what you're doing. You're working from autopilot. So being more mindful, that's one thing I've learned when I was walking in nature last spring and summer. I was really trying to pay attention to the outdoors and how it sounded like, smelled like, felt like, just trying to be in the moment. And that really was a cool little bit of a journey, because I thought at 61 I couldn't learn anything new. But I was learning that, and that was actually pretty gratifying. And then the other one is generosity. Last week, I think, was Random Acts of Kindness Week or something. It was recent anyway. But doing generous, altruistic behaviors for others, doing something nice for other people, that also improves your brain circuits, they found. And Dr. Davidson has got he likes to be called Richie. Richie has actually done some research on this and has data to support the fact that doing nice things, wonderful things for others, helps them, and it really helps you. So those are some constituents to well-being. And resilience, this whole thing can be very contagious. I know after my heart attack, I started getting into the gym. I started eating differently, and I lost 75 pounds and trying to get healthy again. And my brother-in-law, he had gone to the doctor after me because he found out that he needed to be on cholesterol medication and that he was a heart attack waiting to happen. So he thanked me for that. Didn't want to thanks. I didn't care to have a heart attack to do that. But my point is, when you start to take care of yourself, people notice it, and that can be contagious. Other forms of resiliency would be being out in nature. They call it forest bathing, which is kind of an interesting word, but that just means being out in nature, walking in nature, experiencing nature through all 5 senses. Green and blue exercise means you're exercising outdoors, either in the grass or by water. Aerobic exercise is really important, and that's one of my main staples that I do. I've been doing it pretty much for 3, 4, 5 days a week for the last 5 years, doing some intense aerobics. And then there's meditation, which I talked about, and then having that attitude of gratitude. So if all this sounds interesting to you, taking the next step, how do you begin to become a trauma-informed organization? Well, ideally, the leaders in your organization, they need to buy in and have ongoing support. They need to really articulate the why. Why do we want to go through these changes? Because remember, change is uncomfortable. Most people don't like it because it involves loss. So the leader has to really articulate why it's so important to become trauma-informed and trauma-responsive. And then you begin to recruit those trauma champions in your organization across sampling of people. Ideally, you want people that are participants of seeking your services. Those who are receiving your services should be at the table too. But it's always important to start small. Start with a small department or a small area to really focus in on those 6 TIC principles, but then think big. Because then you can begin to develop those human resource practices that are trauma sensitive. You're hiring the right people, your environment changes. Maybe you slap a new color of paint on the walls instead of the institutional white. You've got something more calming. If you can do that, looking for those ways to make your environment more welcoming and friendly. But strive to be intentional, not perfect, because this isn't about being perfect. It's about just being intentional. So to start thinking about, to summarize all this, be attentive to each other, listen to hear, know that your language that you use matters tremendously because your words have power. Replace speech that uses labels, jargon, judgments, and demands with empathy, kindness, and compassion. Begin to do those things, you're going to be in a really, really good place. And then the final thought, every life is a piece of art put together with all means available. And I love this quote because I think about somebody like Tony or Kane, who I mentioned earlier, and you just look on the internet at the images of her mugshots and what this woman went through, and that she landed on the streets out of an act of love for her brothers and sisters. You know, she was judged for 66 times in and out of corrections or treatment. They just didn't think she's ever going to make it. They thought she'll be dead. She probably should be, but she got into a program that saw her as the beautiful piece of art she was always meant to be. And they helped her find those pieces that were missing to make this beautiful tapestry of who she now is. And you can see the pictures of what she is now, and it's just amazing process. So I have time for some questions here. I have a few minutes. So if there's any questions, I do have some resources too. I'll just point those out with hyper quotes. And I will tell you that if you're interested in trauma-informed care and ACEs, I do send out a monthly, it's called Trauma Informed News and Notes. It's through Resilient Wisconsin. But if you go out to that site, to that link there, you can actually sign up to receive my monthly newsletter. It's now international. I had a nurse in Australia reach out to me and was thanking me for the content in that email list, in that newsletter. So that was really cool to see. It's gone beyond Wisconsin now to Australia. So just wonder if there's any questions.
And if you're muted, you can unmute yourself. If you're on your phone, you can do *6. Otherwise, you can unmute yourself and put your video on if you want to ask a question, or the chat option as well.
I was that clear, huh? Wow.
They asked if they could email us the resource list that you have on your slide.
Actually, I'm going to send the PowerPoint to you if that's okay, Carly.
Yep.
And then you can share that with folks. It'll be on there.
Absolutely. And I might need to do it separately with the recording, so you guys will get emails, maybe 2 or 3 of them from me with all the information from today's presentation. Somebody said this is the second time hearing this presentation. First time was pre-COVID. It was good to hear it again.
Yeah. Hey, after you've watched it twice, you get to present it now. So you're now
I would just to say thank you very much. Some of the points really hit home with me, so thank you for that.
Oh, you're very welcome. I'm glad. That's what I hope, that people can see this and see themselves and maybe think about their own situation. I sure did.
I have a question. Can you hear me?
Yep, go ahead.
So is there any specific research being done between linkage of, Alzheimer's and the elderly population from this ACE standpoint? You have many people of that generation who clearly are veterans who, experienced war. And maybe kind of like you talked about, Scott, I'm generalizing here, but, parents of that age or generation, maybe we're a little bit more prone to corporal punishment, and
Right.
that now we would possibly see as abuse. So any studies being done on, maybe the 80 to 90-year-olds and links to Alzheimer's, again, relative to ACE?
That's an excellent question, and I just came across. In fact, I'll see if I can send this study also to Carly. But somebody just made me aware of it. I didn't even know about it until like 2 weeks ago, because I'm part of my list when I'm doing this listserv. I'm always looking at what's going on in the research world. Sadly, there's been nothing around ACEs and dementia. That was what the question was before another training I did. But then I was made aware of a study in Japan that shows that elders that have an ACE score of 3 or more have a much higher chance of having dementia. So it definitely, it's intriguing, and I think that that's the first step. But sadly, there's not a lot of research right now on that. There needs to be. But I think that Japanese study hopefully will light some fires and get some people thinking and looking at that, because I think we need to be understanding this more with the elderly population, because I've been wondering that too. What is Alzheimer's or other forms of dementia? Is there a relationship? Because it almost seems like it would be, right? Because ACEs has been connected to so many mental health and physical ailments that why wouldn't there be a connection? So I really would like to see more research around that. I'll try to get that study and send it to Carly, and she can share that too, because it was interesting.
Great, thank you.
Mm-hmm.
And then Scott, there's another question asking if you could give them the scoring system for the handout on finding your ACE score and the resilience score.
Yeah, good question. The ACE score is very simple. You read the questions and you just simply answer yes or no to those questions. Now, some of those questions may say, I think once it might say stepmother or something. It can be stepfather. I mean, if you've had an adversity related to that, you can answer yes. But any yes response to any of those 14 questions that'd be one ACE. So the scoring is pretty simple. You just answer yes or no all the questions and then count all of your yeses. That would be your ACE score. The resiliency questionnaire does not have a scoring key per se, but I will say that I think the top score you can get is maybe, I can't remember if it's 60 or what, but it's a 0 to 4, is it? I don't have it in front of me. But as you're answering those questions, you want to see responses that are like 3s and 4s, because that would say that those are strong resiliency factors. And those that you score lower are the ones that you can be paying attention to and thinking, how could I get more of that? Or how could I get that factor built more into my life if it's possible? So the scoring for that isn't exact, but I just say, I think 60 or whatever, I can't remember what the total score was, or is 15 questions, 0 to 4, 1 to 4, I can't remember, but yeah, just look for 3s and 4s is a good thing. Anything below 3, start looking at areas that you could be building up and working on.
Okay, the next question, any recommendation of books on the topic of trauma-informed care?
Oh, there's so many. Oh my goodness. I would take a look at that resource list that I sent along. Let me just back up here. Let me see what I have. Those are there's some videos that are pretty good too. You can take a look at those, but trying to see if I have anything in here.
So it looks like there was 2 slides that you just skipped over that said books at the top.
Yeah, there's some books here. The one by Fallon and Harris in the middle of the screen, Using Trauma Theory to Design Service Systems, that's pretty good. Trying to think of another good one. They're all pretty good. The other thing that my quote unquote Bible, if you will, my go-to when I first started learning about this was SAMHSA. They had it's called Treatment Improvement Protocol number 57. If you go to the SAMHSA website, and you can actually download, it's a pretty big document, but it's got everything in there you ever want to know about trauma-informed care, along with exhaustive resource list. It came out in 2014, but it's still very, very good. It's valid. Another good book for taking care of yourself is by Laura Vandernoot-Lipsky, Trauma Stewardship. That's a really, really good guide, and she's got a lot of videos out on YouTube. But yeah, there's so many resources out there. It's hard to think of what's. But those are the big ones, like SAMHSA's Tip 57. I think everybody has that, and I use that a lot. It's got everything in there you want to know about it.
And that will also be sent to everybody's email that registered for as well. Tracy asked, is there a list of trauma and resilience informed trained therapists in Wisconsin that you could share?
Boy, I wish there was. I wish there, in my perfect world, I would have that. There would be a resource list. The thing is, there's no certification process for trauma-informed trainers or providers right now. So it's basically me and a couple other people at DHS who do some training. And then I know St. A in Milwaukee does a lot of training around trauma-informed care. They charge for their classes, but I often list them on my listserv because they ask me to post them on the news and notes. But there is no place to go to find a therapist or a trainer who's trauma-informed, because the only certification I know about really is a graduate program at UW-Milwaukee. In the Helen Bader School of Social Work, they have a track where you can get a trauma-informed certification. That's about the only one I know of, but we need to get there.
Right. Does anybody else have any other questions for Scott? And Scott, it looks like a lot of people, the feedback that they learned new things about trauma, very informative presentation. Thank you for doing this. Any other last minute questions? All right, if not, thank you guys so much for participating in this. I know the 2 hours is a little daunting, but hopefully you guys got information out of it. And again, I will get all that information sent out to you guys, hopefully by the end of today, if not tomorrow. But thank you again, Scott, for all your information and the resources that you provide for all of us.
You're welcome. You're very welcome. I appreciate the opportunity. Thanks, everybody.